So I'm going to speak to you today about paradoxical safety signals from biologics, and I'm going to focus it on two areas. One is on psoriasiform lesions, and the other is on lupus-like reactions. I don't have time to talk about demyelinating reactions, but I will talk about that this afternoon in our session. So if you want to hear about demyelination and how to approach patients with arthritis and treating those lesions, you can attend that session later on this afternoon. It's also hard to stand up here after Jack and Kevin have given a talk, so you have to appreciate it. It's pretty difficult. But anyway, so these are my disclosures in terms of consultancy and research. And I'm going to talk first about cutaneous and autoimmune reactions to anti-TNF agents, and focusing mainly on psoriasiform and lupus-like reactions. I'm going to talk to you a bit about what we believe to be the pathogenesis, although this is still an open question, as many of you know, but very fascinating and evolving. And then thirdly, to talk about the therapeutic approach. And all of you have patients who've developed these reactions, and it can be really challenging as to how to think about treating them when they have an underlying autoimmune or inflammatory disease, and you've got a therapy that actually is working, but they develop one of these paradoxical reactions. So the cutaneous reactions, so you all know that if you look in the literature, there's a wide array of lesions that these patients can develop that are listed on this particular slide. And I'm not going to go into great detail except to say that often when I see patients on anti-TNF agents who develop skin lesions, the first thing I do is pick up the phone and call the dermatologist and say, I need your help here in order to sort this out. And the reason being is because the phenotype can be quite varied, as demonstrated on this slide. So from palmopustular psoriasis, which is the most common variant, to vulgaris scalp psoriasis, interstitial granulomatous dermatitis, which I will discuss in a moment, as well as AGEP, which are two of the more common drug reactions that we see with anti-TNF agents, have to be in the differential diagnosis. Lupus-like lesions have also been described, and I'll talk about that as well in a bit. But more rare reports discuss Sweet syndrome, vasculitis, and guttate psoriasis. So these are all manifestations that you can see in patients on anti-TNF agents for a variety of different reasons, whether that's for RA, psoriatic arthritis, psoriasis, Crohn's disease. So the report that is probably most comprehensive is discussed on this slide. 114 cases, and all of the literature is really case reports. We do not have good data regarding prospective studies. And you can see the underlying disorders, which are listed there. And the most common type that we see, and it's also mirrored in our practice, is pustular psoriasis. And that's an important point because pustular psoriasis in the whole realm of psoriasis is relatively uncommon, but very common in patients who in the psoriasis, who develop psoriasis lesions from anti-TNF agents. Plaque is about half of these patients. And then there have been reports of guttate psoriasis as well. All of the anti-TNF agents have been implicated associated with these lesions, so it's not one more than the other necessarily. And again, we're sort of difficult because these are all case reports and not prospective. And one has to be sure, and in the literature that I've seen in these case reports, they've gone out of their way to show that there's no causative infection and that's related to new drug, and they've tried to rule out other concurrent triggers that might be leading to these reactions. So the potential etiologies of TNF include underlying disease. Is their underlying disease psoriasis, and you misdiagnose them as rheumatoid arthritis? So is this really PSA? You've diagnosed them as RA. That's generally not the case. A systemic infection such as chlamydia or streptococcus, again, in all of these series, cultures have been obtained and have been negative. Reactive arthritis is another consideration. You know that the lesions of reactive arthritis can look just like palmopustular psoriasis. Drug-induced lesions, of course, are what we're talking about today. And I want to now focus more on some of the two that are most commonly seen that are not psoriasiform, and those include acute granulomatous eczematous pustulosis, or AGEP, and interstitial granulomatosis. So here's an example of AGEP. And you can see that it's sort of widespread pustular lesions shown on the right. on the left, excuse me, and on the right is the pathology, which, as you can see, are really pustular lesions, which are filled with neutrophils, and then the infiltrate underneath this is usually palisading lymphocytes and also eosinophils. The reason that this is somewhat distinctive as opposed to palmar pustular psoriasis is the widespread location. So it's not just on the palms and soles, but it's widespread. This is a drug-induced reaction. You can see it to anti-TNFs and to other agents, and the treatment is to withdraw the agent, and it will improve rapidly. You don't need to use oral steroids. You don't need to use topical steroids. Just take away the drug. And this has been reported in several series in patients on anti-TNF agents. Another common eruption you've probably seen in your practice, I know we have, just recently had a case of this, is interstitial granulomatous dermatitis. And this is observed in a variety of situations in lupus, RA, vasculitis, and other disorders, but also can be induced by anti-TNF agents. And it has a variable appearance. As shown on this slide, these are basically raised plaques that can be umbilicated, but they can have other appearances such as cords, and they can be on the trunk or extensor surfaces as shown here. And they are observed after exposure to anti-TNF agents. And again, the treatment for this is to withdraw the agent, and it will improve. Now, the biopsy here is very characteristic. It's a granulomatous reaction with palisading histiocytes around degenerating collagen. And again, I've seen several of these cases on anti-TNF agents, so it's not all that uncommon, both in our practice and what's been reported in the literature. And the most common presentation in the psoriasis world to a paradoxical reaction to anti-TNF agents is palmopustular psoriasis. Now, this is particularly interesting because it's relatively uncommon out in the population that are not on these medications. And it's different from vulgaris in that it's more common in female smokers. It's not associated with the CW6 allele, which, as you know, psoriasis vulgaris is very tightly associated with that particular genetic MHC molecule. And these are really difficult to treat. Again, I'm sure you have some of these patients in your practice, and this is where you're working hand in glove with your dermatologist to try and clear this up because there are not good therapies out there, to be frank. Guttate psoriasis is rare in the setting of anti-TNF agents. These are teardrop lesions. They're associated with a different immunogenic profile than the palmar pustular, so CW6 does creep in here very strongly, and they usually arise in the setting of a streptococcal infection. So I've seen this occur in patients on anti-TNF agents in the setting of a strep infection, and they develop these lesions, and they're quite distinctive. Plaque psoriasis, of course, about half the patients develop this lesion associated with CW6. There's early and late onset. It's a most common phenotype in the general population, so this becomes a situation is trying to figure out whether or not they had underlying psoriasis or it was triggered by the anti-TNF. These it can mimic, as I said, psoriasis vulgaris. For me, the important clue here is when patients develop these lesions and they seem to get worse right after they've gotten their anti-TNF, that's much more likely to be drug-induced. Whereas vulgaris, let's say they're on a drug like infliximab, usually they'll tell you, oh yeah, my skin gets better after my treatment, and then a little bit later it sort of breaks through. That suggests underlying vulgaris and not a drug-induced reaction. So what about lupus-like reactions to anti-TNF? I'm sure you see these as well. I know we do, and they're a real problem for us and for the patients. So one of the case series that I pulled out and I think is instructive were 22 cases of drug-induced lupus in 866 patients in the French Biologics registry. 10 had skin disease and 12 had systemic disease, so about a 50-50 split. And you can see where the mean onset of symptoms was about 9 months after the starting of the medication. And in this case, they saw them both in etanercept and infliximab. And 8 patients required steroids. Most of these were topical. And you can see that generally, if you withdraw the anti-TNF agent within 8 weeks, in almost all these patients, and this is generally throughout the literature, the lupus-like reactions resolve and don't generally require immunosuppressive or corticosteroid therapy. And you can see here the incidence. Again, these numbers are not population-based, so I don't think they're very credible. So in your slides, I have a more detailed table of the 4 studies, but I thought for this presentation I'd boil it down for you. And these are the manifestations that you see in patients who present with lupus-like reactions on anti-TNF agents. So a positive ANA is seen in the majority, and these are out of 158 patients out of 4 studies. You can see that most of them have immunologic abnormalities, and the most common is anti-double-stranded DNA antibodies, which are usually IgM. They can have a discoid rash, and less common features include hematologic reactions, generally cytopenias, arthritis, serositis, photosensitivity, and renal involvement was only reported from 1 study in Spain, and obviously is pretty uncommon. So what I look for in these patients are skin lesions, an ANA and a double-stranded DNA, and not mentioned here is that antiphospholipid antibodies are also relatively common, seen in about 20%, and not associated with thrombosis. More commonly IgM, but some can be IgG. So these are the phenotypes of the patients that develop lupus-like reactions with anti-TNF agents according to case series. What about the autoantibody profiles? I'm taking one series, the paper that shows 3 different series, again, shown in your slides that you have with you, and that's just showing you, again, a predominance of anti-double-stranded DNA antibodies, more likely to be IgM than IgG. You do see anti-histone antibodies, but unlike other drug-induced lupus, it's not the only antibody that you see. And you can, shown below are the ENAs, which are also not uncommon in some series. Pathogenesis. So you're all aware of a very important paper that was published many years ago by Jacques Bonchereau and Virginia Pasquale that talks about this axis of cytokines that's important for maintaining homeostasis. And these include interferon gamma, as shown on the top, interferon alpha to the left, IL-4, and TNF. And so during times of viral infection, we see a skewing toward gamma interferon, and we know this is very important at generating the cytotoxic T cell response to viruses. In the case of arthritis, evidence would suggest, and of course this was before the Th17 paradigm came into view, which was in 2006, that TNF is a major cytokine driving the inflammatory reactions in rheumatoid arthritis and also to a certain degree psoriatic arthritis. Whereas we know with allergies that the IL-4, IL-13, IL-5 pathway seems to be the predominating cytokine that drives these very unique reactions. So could it be that in patients on anti-TNF agents that this very delicate homeostasis is disturbed? And the answer is evidence would indicate that is what happens in some patients treated with anti-TNF agents. So I'm not going to walk you through this whole slide. I just want to point out one important point, which is down in the lower left-hand corner of this slide, and that is that there is compelling evidence now that psoriasis is initiated by plasmacytoid dendritic cells, which ingest DNA bound to a cathelicidin called LL37. And once those plasmacytoid dendritic cells take up the LL37 DNA complex, they start to release large amounts of alpha interferon. And work from Frank Nestle and others have shown that this alpha interferon response is very early in psoriasis and a key element that drives the pathogenesis. Not unimportantly, is the same pathogenesis has been described for lupus. If you go to the New England Journal of Medicine about 2 years ago, they describe this very elegantly, and there's a number of papers that have outlined how this LL37 DNA complex may be driving plasmacytoid dendritic cell interferon production in LE. So here we have 2 disorders triggered by TNF that may have a common pathogenesis. So basically, there's a shift to an interferon signature which can drive a Th2 profile through the release of IL-10, which may be important in the lupus-like reaction. Another potential explanation shown here, or others, include necrosis of cells by TNF, and these cells release nucleosomes, which then drive an autoimmune reaction. TNF may interfere with apoptosis, and there's some evidence for that, and then a decline in T regulatory cells are another potential explanation, and I'll talk about these individually. So here's evidence for the concept that interferon is induced in patients who are taking anti-TNF agents, and that's associated with psoriasis. This work was done by Jan Dutz in Vancouver, who's a rheumatologist and a dermatologist. And basically on the left, you're looking at a biopsy of the skin of a psoriasiform lesion in a patient who was treated with anti-TNF agents. And on the right, a patient with psoriasis vulgaris in the absence of TNF. And what strikes you is that on the lower left-hand corner in the TNF antibody-treated patient, you can see that there's staining for the epidermal myxovirus resistance protein, which is an alpha interferon-induced protein. And what's intriguing here is that you do not see that type of upregulation in patients with psoriasis vulgaris. So this would indicate that in patients with anti-TNF induced psoriasis that there is an interferon pathway that's being induced. The other data comes from animal studies, and I keep thinking about Ed Keystone, and if I had a mouse walk into my office, and I'd use these data, but it's still instructive, I think. And this is from the Wyeth group from several years ago in A&R, and basically what they did was to take a mouse model of psoriasis, and that mouse model is one in which you give mice CD4, CD45 high T cells that are adoptively transferred into a mouse model, a SCID mouse model, and they develop psoriasiform phenotype. Well, as you probably know, it's very difficult to really see psoriasis in a mouse because they're covered with hair, and so it's really not a great mimic of the human disease. Nonetheless, this is one that's commonly used. And in this study, they basically did two things. One was to give an isotyped control treatment to these mice once they developed the psoriasis. One was to, another group got treatment with anti-P40 antibody, and another group of patients got to treat mice, Ed, with a soluble receptor TNF molecule. And the results are quite striking. So if you look at the isotype and the IL-23/12 antibody mouse treated on the top, you can see that the isotype really has quite profound psoriasis in the ear and on the nose, and when you give them an antibody that blocks P40, you can see that that is no longer present. In the lower panels on the left, what you're seeing here is when you give an isotype, you see the psoriasis in this mouse model, but when you actually give a soluble TNF molecule, it actually gets worse. And that is documented on the right, where you can see in the graphs that those patients that got the anti-P40, that the score of the disease severity went dramatically down. In patients, mice that received the soluble TNF receptor molecule, that this went up significantly. So here's another evidence, at least in murine model, that potentially TNF may be very important at driving a psoriasiform phenotype. Well, what's the mechanism? So they explored this more carefully, and what you're seeing is in the black bars on the right are the mice that were treated with a soluble TNF receptor, and note that there's elevation of IL-17A, IL-22, IL-21, IL-1 beta, all implicated in the pathogenetic pathway of psoriasis, whereas other molecules such as interferon gamma and IL-6 were not elevated compared to the isotype control. So the way that I view the pathogenesis, at least in the psoriasis side, is it probably is related to an induction of an interferon response and also upregulation of the Th17 pathway. Whether that is true or not, I don't know, but it makes you think that maybe one approach that you could use to treating these patients, if they, for example, they have psoriatic arthritis and they're developing this on a TNF, would be something that inhibits that pathway, such as an anti-P40 antibody. In RA, unfortunately, that's not a viable alternative. The other important piece of information that they pointed out in this study was that the Treg cells in these mice that were treated with a soluble receptor go down as well. So there may be a more global effect on the immune system that involves not only the Th17 and interferon alpha, but also a decline in the T regulatory pathway. So what about lupus-induced disease? Well, I don't know. There could be a shift to this interferon signature, and support for that comes from a study that was done at HSS by Peggy Crow and colleagues. Now, these are Sjogren's patients. I know it's not lupus, but it's the closest that I could find. And so these are 20 Sjogren's patients that were treated with etanercept. and they had Sjogren's syndrome according to the criteria of the time, which is published in 2007. And this double-blind randomized controlled trial of 20 patients where 10 received etanercept and 10 placebo, the results are shown here. And they did not respond clinically, by the way. It was a negative trial. But what was most instructive for this presentation was that you're looking on the left, the upregulation or the change into a type 1 interferon signature in the patients that received etanercept versus those patients that received placebo. That was not observed. In addition, on the right, you're looking at the BAFF levels in the patients that received etanercept that go up compared to the patients that received placebo. So it does appear in Sjogren's syndrome, a related disease to lupus, albeit not the same, that one does see the development of an interferon signature following treatment with anti-TNF agents. Beyond that, I don't have other insights because this has not been carefully studied, but I still think this is a very attractive explanation for the pathogenesis of lupus in this population. What about treatment in closing? Oh, this is a horrible slide. I was going to change it all, but I put it in your deck, so I thought I should probably address it. So I think this is an accurate way. This is how we approach this. So on the left-hand side, in those patients who have severe psoriasiform lesions, and I'm first talking about psoriasis-like lesions, if they're really severe, and you've probably seen some of these, they have terrible palmopustule disease, they have terrible psoriasis, it's really disabling them, and we see that once in a while in the anti-TNF group, you have to discontinue the agent. And once again, I work very closely with the dermatologist, so before doing that, we get a skin biopsy, we make sure there's no infection, we make sure this is an HEP or interstitial granulomatous dermatitis, or actually psoriasis vulgaris by the history, and psoriasis vulgaris should not get worse when right after their treatment with a drug in general. So the treatment of these lesions from the dermatologist is topical steroids, as well as salicylates, keratinolytics, topical vitamin D analogs, and sometimes we go on, and we've done this with dermatologies to treat with cyclosporin or acitretin when it's very severe. As you probably know, this can be a big problem. Also, with the palmar plantar occlusive dressings at night, and sometimes topical agents such as tacrolimus or Protopic can be helpful. For those patients that have less than 5% body surface area, so less severe psoriasis, we may keep the anti-TNF agent going and try and treat that and see how they do. I've done this rarely because usually what we'll do if their psoriasis is not all that severe is to switch to another anti-TNF agent. And there are reports, and we've seen this, where it's not always a class effect. So sometimes you'll see patients improve when you go from one to the other. And again, you've got to treat the underlying disease. So in those patients who really, it seems tolerable to them, but their involvement is pretty severe in terms of body surface area or a palmar plantar disease, switching to another agent, I think, is a very viable alternative and sometimes works. And then, again, you still have to treat the underlying disease in concert with dermatology. Again, this is in your slide deck, and I just thought it was important to go through because I think this is a rational way to approach these patients. What about drug-induced lupus, anti-TNF-induced lupus? The data shows that if you stop the anti-TNF agent, that in most cases the manifestations will completely clear in 4 to 8 weeks. And for patients who persist, which we've never seen, what's described in the literature, you can obviously go on to treat these patients as if they have systemic lupus off the anti-TNF agent. Generally, we've had to switch these patients to non-anti-TNF agents, and certainly our options in the last several years in rheumatoid arthritis are many. In psoriatic arthritis, it's more of a problem because we don't have that many alternatives right now. So in conclusion, I've talked to you about the cutaneous and autoimmune reactions related to anti-TNF agents. These are a major issue in our practice, and I'm sure in yours as well. And the pathogenesis is not clear, but I believe that it probably centers at least in the transition to an interferon alpha dominated pathway, although other mechanisms, including Th17, may be at play, particularly with psoriasis. And that the therapeutic approach in the skin disease is more nuanced, that may involve either stopping a drug or switching to another anti-TNF. In the case of lupus-induced reactions, you really need to stop the anti-TNF agent, and there are a lot of other options for RA to treat, whereas psoriatic arthritis is more limited. We now have the anti-P40 antibody as an option as well. So I'm going to stop there and show you a picture of Rochester, New York, about 4 hours from here, that actually is starting to look like that now, and I appreciate your attention. I'll take any questions.